Hello, everyone. Welcome to the Mainstream Mondays session. And I'm very excited to co-discuss with one and only Youssef today, who always inspires us and encourages us. And Youssef, would you like to say hi? And then maybe we can let our case presenter and people who are making this happen say hello.
No, thank you, Seema. I'm really excited to discuss with you today. Seema, do you want to tell them what the session is and what people should?
Yeah, so these are Mainstream Monday sessions, and in these sessions, we focus more on the clinical reasoning, but also on how to manage these common conditions. And so these are mostly bread and butter cases, but we are open to bread and butter cases all the other days as well. But these are something we are focusing on today. So excited to see how it goes, and I'm just here to make mistakes and then learn from my mistakes.
Yeah, that's great. So we encourage you all to sign up to present cases. You can do that on the website, clinicalproblemsolving.com, and then present a case. And then it can be any like bread and butter cases welcome, which makes it even more fun and more similar to residency, where the majority of cases that you see are actually bread and butter in real life too. Uh, our very own Lyra is scribing today. Lyra, do you want to say a word?
Absolutely. Hi, everyone. Excited for the session.
Awesome. And let's see, Mohammed is doing the teaching points. Mohammed, do you want to say hi?
Hello, everyone. I am Mohammed. I'm excited for doing teaching point for today's session.
Awesome. And the one and only Aaron.
Everyone, it's me again, presenting another case. Yeah, I originally wasn't supposed to present today, but I had this case for a while and wasn't really sure where to present it. But given this Mainstream Monday space, I felt it was more appropriate here.
Awesome. Can't wait to hear it. So whenever you're ready, we can go ahead and get started.
All right, so for the first aliquot, we have a 45-year-old female coming in for fever.
Steve, the floor is yours.
Yeah, fever is a very interesting chief complaint we often come across. So we consider it the I-made mnemonic, I for infection, malignancy, autoimmune, drugs, and then everything else. But I just think that getting some more information in terms of how long this has been going for and if the patient had any associated symptoms can help us make some progress. What do you think, Yusuf?
Yeah, I love that. And Simi, if let's say you say I made, do you think what percentage do you think of fevers are I? What percentage are M? What percentage are A, D, and E? Which one do you think is going to be?
I think infections are far more common causing fevers because there's this cytokine storm causing fevers and things like that. So I think infections would be my top. And 45 makes me also think about possibility of autoimmune. But I think malignancy is possible, but lower on my differential given the age.
Yeah, I think so. So I think like even though we say I made, maybe 99% of fevers are going to be infection, right? You're rarely going to have malignancy present just with a fever or autoimmune disease just with a fever. And I like to think of the five most common infections in hospitalized patients, and these are always good to like keep in the back of your mind. So this includes like skin and soft tissue infection, pneumonia, urinary tract infection that gives a thumbs up, intra-abdominal infection, and bacteremia of unknown source or bacteremia. And these are the five most common. And these think if you think about it, these are the 99% of fevers. So uh, if I were going to see this patient, these would be the questions I would be asking. Like, out of these five, do you have like lung? Do you have urinary? Do you have abdominal symptoms, or is it just fever? So, Aaron, can't wait to hear more.
All right. So for the next aliquot, I'll give you the HPI. So the patient has been in her usual state of health until 2 days ago when she noted onset of fever, Tmax 39.8 Celsius, and this was associated with chills. She had no associated cough, colds, sore throat, dysuria, hematuria, headache, dizziness, nausea, vomiting, or abdominal pain. So she took Tylenol every 4 hours with relief of the fever. One day prior to her presentation, she was actually able to go to her dialysis session without any notable events. She had no fevers or chills at that time. And a few hours prior to her presentation, she noted right shoulder and upper back pain associated with a right-sided headache, rated at 5 out of 10 in severity. She had no fevers or chills at that time. Since she had these new symptoms, these constitutional symptoms associated with her fever, she went to the ED for further evaluation. The ROS is otherwise unremarkable.
Wow. Excellent, like history presentation, Iran. Seeme, what does this do for you? What are you thinking?
Yeah, I'm just thinking that if this headache and these shoulder pains are just a consequence of the fever the patient has, or do we have to think of these causing the fever, or is it something we can localize on, but we don't have any other complaints like abdominal pain, but we do have upper back pain. So just thinking about if the patient had any procedures in the past, and the duration of 2 days makes fever due to infection most likely, just like Youssef, you mentioned.
Awesome. And what are you thinking of? Two things. One, the shoulder. Like, how does one develop pain in the shoulder? What do you think about that?
Yeah, I'm just thinking that is the shoulder pain just due to the cytokine storm, but that could not be limited to just the shoulder. So if the patient had any trauma to the shoulder before this, or if this is limited to just shoulder or other joints are also involved, or just thinking about any sort of inflammation versus trauma, or if the infection started in the a shoulder, if it was the focal point for the shoulder. What do you think, Yusuf? Is it a cause or is this more of a consequence?
Yeah, I think we hear the story here. The patient has a fever and then they have shoulder pain, right? So you wonder if like the fever started, they developed an infection, and did the infection like seed the joint? And again, going from the frame of infection is the most likely, and we didn't hear a history of trauma here. Do we have a septic arthritis that we have to think about? Either primary, like you said, from trauma, or it could be hematogenous from bacteremia. So I'm wondering, what do you think about dialysis? How does that link with infection in your mind, Simi?
Yeah, if there were no dialysis, it would be hard to think of a focal point for entry of the infection. But given the history of dialysis, I wonder if this is something that makes patient more of immunocompromised host, or is this something that when he was getting the session, there were some bugs that entered the body during that session and caused this type of presentation. So yeah, that's what I'm thinking about. But I think getting some more information would help us narrow our differentials. But just thinking about the infection at this point, but what bug or what exactly is causing that is difficult to say at this point.
Yeah, I love that. So dialysis causes immune compromise, but it causes immune compromise via two mechanisms. One is your kidney is not functioning well, and you can have uremia, and that alone can cause like some autoimmune dysfunction or the abnormal functioning of your white cells. But the other one is a structural immunocompromise. So you already mentioned it, like you have a line that goes into your body 3 times a week, and that line exposes you to the world, and that line can introduce infections. And the other trick is that in shoulder pain, the shoulder can be the primary location of infection, but it can also be a point of radiation. If you think about it, a common presentation of myocardial ischemia is left shoulder pain. And this can happen anywhere close to the left diaphragm. So you can have like a splenic injury presenting with shoulder pain. You can have a splenic abscess presenting with shoulder pain. You can have a PE present with shoulder pain. You can have an MI presenting with shoulder pain. And the big trick here is what do you find on exam? So if somebody has a septic arthritis of your shoulder and you move it, it'll be very painful. While if it's referred pain from the abdomen, the exam of the shoulder will largely be unremarkable. It's going to be referred from your abdomen, so it will be slightly different. And anybody who's on dialysis, you need to have a lower threshold to get blood cultures. So bacteremia, oftentimes we think of bacteremia, oh, you're going to have chills, fevers, rigors. But if somebody who has dialysis, it's way less likely that they present with these symptoms. So the first time you see the patient, you're going to think about, okay, how's the shoulder? is the shoulder okay? You're gonna screen for like COVID, flu, RSV. But then if all your screenings are negative, you need to have a very, very low threshold to obtain blood culture. So I'll be on the lookout for that. And then final question, Seema, is what are you looking for on exam? Like, let's say right now you get this, the ED calls you and they have this patient and you're going to see this patient. What are you going to do on exam?
Yeah, that was beautiful, Yusuf. And I'm just thinking on exam that we might find some point other than shoulder, or is this just the shoulder? And just like you mentioned, is it that shoulder? The patient cannot move it, or is it just some tenderness and then the focal point is somewhere else? So that is what we can see on exam. But also, I think that we can see if we can see any of the dialysis catheter site for any sort of redness or any collection of fluid or anything like that. That might help us make progress. And yeah, that's what I think. And if we can think, we can see if the orientation is well or if the patient is altered. And also, I think the presence of chills and rigors, I think was mentioned in the chat, shows that the fever is very severe. And yeah, that's what I'm thinking about.
Yeah, I love that. I think good shoulder exam, looking at the site of dialysis. I think a good extremity exam, you can look for sites of like septic arthritis, any like ulnar nose or Janeway lesions. It'll be like a quick, easy exam. And then everybody gets like a skin exam and abdominal exam, and we can auscultate. So Aaron, I can't wait to hear what you did.
All right, so just some more history. The patient is hypertensive, dyslipidemic. She is end-stage renal disease on hemodialysis Tuesday, Thursday, Saturday via a right IJ catheter that was placed 2 weeks ago at an outside hospital. So for her medication, she's on amlodipine, atorvastatin, EPO, and ferrous sulfate. For notable for previous smoker, 1.5 pack a year, occasional alcohol use, no illicit drug use, and yeah, she works in a bank. She was actually admitted 2 weeks ago for oliguria and was dialyzed. That was when she had her IJ cath placed, and she was sent home after that. And I'll stop there.
Aaron, is it okay if we get like one more adequate or the exam so we can
Yeah,
like make
sure.
a little bit more progress?
Sure. So in the ED, we got her. So for her vital signs, she is febrile to 38 Celsius. Heart rate is 63. Respiratory rate is 20. The O2 sat is 99% on room air. She's awake, alert, not in distress. Her shoulder exam is unremarkable, full range of motion, no swelling, no warmth or erythema on the shoulder. The upper back was normal as well. A very unremarkable MSK exam. For her IJ cath, it was in place in the on the right side, no discharge, no surrounding erythema, non-tender while palpating around it, but she said there was like minimal pain. And she says it always has been, so nothing new for her. Lungs were clear, heart was normal, otherwise no swelling to the lower extremities. Otherwise, unremarkable exam. And I'll stop there.
Awesome. Thank you so much, Aaron. Simi, what progress have we made right now, or what are you thinking now? And it sounds like we hear that the shoulder is fine, and no like erythema, swelling, or tenderness, which is like different than what we heard, right? Shoulder pain, but normal exam. So what are you thinking?
Yeah, that was interesting. And I think that getting some more history helped us make some progress in terms of who is this host. So given the smoking history and dialysis history makes me think that the patient is prone to getting some more infections and is in an immunocompromised state because smoking itself is a risk factor as well. And it was interesting that the shoulder range of motion is normal and seems to be more of a distractor than shoulder being the focal point. But I think that we cannot see any discharge or edema at this point. But the patient has minimal pain at the site. There are no other focal points. So maybe just a systemic process and then cytokine storm causing all these symptoms the patient has. And we did have back pain, but on exam, there was nothing found significantly in terms of that. And I think the patient was given something to control fever, but I'm still wondering, should we start this patient on broad spectrum antibiotics, or Yusuf, what do you think about that? Is it a good point to start treating with broad spectrum antibiotics, or do you want the cultures first?
Oh, do you want the cultures first?
I think it would be a good way to send the cultures, because if we start antibiotics, cultures are going to be negative. So just send cultures first, and I think then start empirically on antibiotics. But would love to learn how would you approach this?
Yeah, I think in the beginning of the session, we said 99% of fevers are infections, and we said the most common infections are pneumonia, skin and soft tissue, UTI, intra-abdominal, and bacteremia. So out of these five, which one do you think we're thinking of at this point in time?
Yusuf, I think we're thinking more of bacteremia at this point, but yeah.
Exactly. So that's where I'm at too, right? We have the pneumonia is less likely, no oxygen requirement. We see no like crackles or decreased breath sounds. Skin and soft tissue, we didn't see anything on exam. And then UTI, we didn't hear about any symptoms on the history. And intra-abdominal, it seems so far it's non-tender. So now we're thinking about bacteremia. And whenever you want to like treat an infection, you have to think what are the most likely organisms before you even treat. Because if you want to think about the syndrome and then tailor your antibiotics accordingly. And in this case, we're thinking about bacteremia. If we're thinking about bacteremia, you want to think about what is the source of the bacteremia. So in this case, we have a catheter that's in the neck going directly into the blood vessel. And so the organisms are going to be the organisms that live on the skin and they go directly into the blood. So it's mostly gram positives for the most part. So you think about like your staph, your strep, etc. So that's going to be the main thing you want to cover. So in general, when I think about empiric antibiotics, I think about they want to cover gram positives, negatives, anaerobes, and then what are like special organisms. So gram positives, definitely, because they live on the skin. Gram negatives, maybe not necessarily in this case. It's like mandatory. Anaerobes, also not necessarily. But MRSA is going to be the one that you want to cover for because it lives on the skin. So I think of vancomycin as an antibiotic specifically for MRSA. I don't think of it as for gram positives. I think of it specifically for MRSA. So you only start vancomycin if you want to cover MRSA. So that's one thing you can consider. And then you can consider to add like either ceftriaxone, and that covers like most gram positives and some negatives as well. And I don't think we necessarily need to do like anaerobic coverage just because we don't hear about like a GU infection or intra-abdominal infection. Somebody asked in the chat, what's the difference between chills and rigors? Chills are the subjective feeling of having chills, like you feel like you're shaking. Rigors is when you witness like your entire body like moving. And what's the difference between the two is that chills can be like sometimes the patient it might be cold outside and they feel like they're having chills. Having chills is very common. So while rigors, where like objectively their entire body is like shaking, has a very high likelihood ratio to predict bacteremia. So if you ever witness someone with having rigors, you immediately want to get cultures on the spot. And then if you get cultures on the spot, you have a very high likelihood of catching a bacteremia during that time. So that's where I'm at. I think I'm still at the 99%. I wouldn't want to sway until, like, I wouldn't want to think of malignancy, autoimmune, or other etiologies because this is acute. This is acute fever over a day. If this was subacute or chronic, it would be a different story. This is an acute fever, so vast majority are going to be infectious. And until I'm convinced it's not an infection, I'm not going to change my mind to consider even like anything else until like first few days. If let's say the cultures are all negative, then we'll talk about something different like TDX. And then the final question is like, how are we looping in the shoulder pain? So we hear that they have left shoulder pain with a normal exam. So where is the pain coming from? So could this be intra-abdominal? Question mark, right? Because could it be from the heart? These are the two big questions that I have. So I think, what am I going to do next? I think, like you said, cultures, antibiotics, and then from there, depending on what we find, I might consider like imaging or see if like any exam findings develop, and then we can consider like abdominal imaging or cardiac imaging, depending on what we find on the culture. So, Aaron, can't wait to hear more.
All right, so for these last two aliquots, it's just the relevant lab workup. So for this aliquot, I'll give you the CBC. So her WBC count was 14K. Her hemoglobin was 9.5. Her platelets were 125, and her MCV is 89. For her chemistries, her creatinine was 6.1, but her baseline is 6.6. Her GFR was 8. Her BUN is 32. Sodium was 132. Potassium was 3.6, and chloride was 96. The UA was just remarkable for glucose positive and large blood, and RBCs 62 and 1 WBC. And then we also got a chest x-ray, which was unremarkable, no focal lung opacities, minimal left-sided pleural effusion, or basal pleural thickening was the read. And then, yeah, that's the aliquot.
And Aaron, should we just get to the final aliquot as well? Because these
Sure.
sessions are usually a little bit shorter.
Okay. So we also got our blood cultures. So we got central and peripheral blood cultures. Both central and peripheral brought on grew Staph aureus. Yeah. So yeah, that is the aliquot.
Wow. Seeme, the floor is yours.
Yeah, I don't think there was something very unexpected in the labs. That was something we were already predicting. And the elevated WBCs, we were thinking about infection, that kind of confirms that. And I'm still thinking about possibility of getting an echo for this patient as well, because I think that just the peripheral catheter might be just serve as we link IV drug use to possibility of endocarditis. I think catheter can serve like that as well. So just thinking if the patient has something more than just bacteremia, and also Staph aureus makes me think about possibility of endocarditis as well. As for the urine analysis, Yusuf, what do you think? It is something we should focus on, or just more of a noise than being actually of importance?
Yeah, so urine analysis is always important to interpret in the context. Like, what context are we getting urinalysis? Urinalysis alone does not give you information about an infection or not. It only gives you what matters is the context. So somebody has this urinalysis and they're asymptomatic, no kidney injury. It doesn't necessarily mean anything. It just means that, like, okay, they have some pyuria, some bacteriuria. Like, RBCs are not normal. So it's almost always never normal to have RBCs in the urine, but does not necessarily mean that there's an infection. So if this was like an older smoker, you would consider repeating that outpatient. And then if it's still there, you want to get a CT urogram to make sure there's no kidney cancer, and then a cystoscopy. If this was like an older woman, you want to see if she's menstruating, right? Because that alone can cause RBCs. If it's white blood cells, again, no symptoms, then doesn't matter. Could there be like bacteriuria? You just repeat the outpatient. If it's a setting of AKI, then it could be interstitial nephritis, something to consider. In a patient who has no abnormalities, urinary symptoms, etc., I would not even think about the UA. The biggest thing is we have this whooping gram-positive bacteremia, which is Staph aureus. So I made a schema on Staph aureus bacteremia that I'm gonna share in the chat. So on our infectious disease episode. So whenever you think of Staph bacteremia, you want to think about where did it come from and where did it go. So in this case, the options for Staph lives on the skin and mucosal membranes. So could it be coming directly from the skin? So you think about like the IJ catheter. Did it go directly into the catheter and cause bacteremia? Because we don't hear about the cellulitis, phlebitis, any other like etiology. And then the other big thing you want to think of is where did it go? So if it starts in the blood, did it stick anywhere? So where can it stick? So it can stick in the heart. It can cause endocarditis, like you already mentioned, Seeme. So in this patient, they're probably going to get a TTE. And then if that's negative, they're probably going to get a TEE. So that's endocarditis. You want to, depending on how good the echo was, you have to do a daily exam. And on that daily exam, you check all of their joints. And you actually palpate them, every single one, to see if there's tenderness, because it can seed any joint. It can cause an abscess. It can cause an intra-abdominal abscess. That can cause this shoulder pain. It can cause meningitis. It can infiltrate the spine. So every day when you're seeing this patient, if you were the intern, you would feel every one of their joints. You'd feel every one of their vertebrae, and then you would ask about where this infection is seeded. And then lastly, you get a repeat blood culture. So you keep repeating the cultures until they're negative. And then you get an infectious disease consult because that's associated with a mortality benefit. And then depending on if this is a complicated bacteremia or not, so complicated by endocarditis, that can determine the duration of antibiotics. So if it's just bacteremia, then it could be as short as 2 weeks. If it's endocarditis, it will be as long as 6 weeks. So depending on what complications you find. And then you want to think about exchanging the catheter that is the source, because that's the source of the bacteremia. And I put the schema in the chat already. Aaron, can't wait to hear from you. What did you all do?
Yeah, so agree. Everything you said was basically done. So our diagnosis was just a catheter central line associated bloodstream infection secondary to Staph aureus. This patient was initially given empiric antibiotics in the ED. She was started on ceftazidime and vancomycin, as you said, to cover for MRSA. And after sensitivities came back, everything, it actually was just, they put ID was consulted and they put the patient on levofloxacin after the sensitivities. The patient also received a 2D echo, which was unremarkable. The patient improved after antibiotics after a few days, no recurrence of fevers, and then the shoulder and back pain never reoccurred. We just attributed that to the initial bacteremia and the site of insertion of the IJ cath. But otherwise, she was eventually discharged. Blood cultures became negative, and they exchanged the catheter. Yeah.
Wow, I love this case, Aaron. Excellent case, and you're gonna see these like so often in residency. So this highlights how important these VMRs are to like get really, really good at the bread and butter cases. Seeme, you called it. What are your reflections?
Yeah, thank you so much, Lira, for scribing, and Mohammed for teaching points, and Iran for bringing the case on such a short notice. And Yusuf just beautifully explained everything. And I want to say the people on YouTube just missed the wonderful schema. So if you guys had joined live, you could benefit from that as well. So yeah, just beautiful learning the bread and butter. I really wanted to link the urine analysis, blood, and then smoking history with something more of a cancer or something like that. But that was just wonderful learning from Yusuf that we have to see what is signal and what is noise and common things being common. So we should think about that. So that was the learning point for me.
Awesome, Seeme. Mohammed, can't wait to hear from you.
Thank you, everyone, Aaron, Simi, and Yusuf, for this session. So it was an amazing session, and we started from talking from fever, the chief concern of the patient. So we talked about the IMAID demonic, and we said that the most common, it was an infectious etiology, surpass other etiologies of fever. And the sources are typically from the lung, pneumonia, urinary tract infection, or abdominal or skin and soft tissue, or bacteremia. In this patient who have had the new place on dialysis, she has sources of immune compromise that put the patient susceptible for infections. And the mechanism of immunocompromise are either uremia, causing immune dysfunction, or it is structural immunocompromise through dialysis line. So we have to consider infections early on in patients on dialysis. The patient also complained from shoulder and upper back pain. Here we want to distinguish whether it is something infectious like hematogenous septic arthritis or radiated pain from, like, for example, from the abdomen. We can do this by physical examination and range of motion. After that, we have known that the patient have no localizing infection to one of the organs, so our mind is shifted towards bacteremia. So here we prioritize blood cultures and covering antibiotics according to what do we think it is the organism for that patient. This patient on recent dialysis have installed an internal jugular catheter, which placed the patient for high risk for a gram-positive, for example, staph and streptococcus from the skin. So we consider covering Staphylococcus aureus, especially MRSA, by vancomycin. If the patient have another localizing symptoms or infections like genitourinary or GI infection, we will consider coverage for anaerobic and also gram-negative. Thank you very much.
Yeah, thank you so much, Mohammed. Excellent teaching points. I loved it. Thank you everyone for joining. Look forward to all these like bread and butter cases. Love learning these and mastering the 99%. So hope you all have a wonderful day.